Okay, well, let me welcome everybody to HealthWatch USA's webinar on C. difficile. I'm Kevin Cavanaugh, and I'm the board chairman of HealthWatch USA. We're a nonprofit organization. Originally based in Kentucky, that's our official home, but we're certainly national at this point. And I'm really pleased to introduce Clifford McDonald, who is the Senior Advisor for Science Integrity at the Centers of Disease Control and Prevention. He is also, I believe, their head person spearheading the effort to control the C. difficile epidemic. And I know that this has really been a perplexing area for myself because C. difficile is so different than other types of infections that we've encountered, both in diagnosis and treatment. And I am really very much interested and very appreciative of Dr. McDonald coming here tonight to share his thoughts and insights. So at this time, I'd like to turn the program over to Dr. McDonald. Thank you.
The focus tonight will be to try to hear your questions and try to respond to them. Just first, I'll just say I have no financial disclosures, of course, being from the CDC. The other thing is, of course, I always have this disclosure that they're not officially cleared at the highest levels of CDC. Just some background here. Clostridium difficile infection is caused by an anaerobic bacterium. It's not a normal part of the intestinal microbiota or the bacteria in the lower intestine. That's often people think that. They think, well, we carry this all around with us all the time. I'll show you some data that there are times when it is being carried, but it's always because of antibiotics, generally. It spread through the fecal-oral route. It's caused, the bacterium forms spores, which are an important issue. The disease is really caused through toxins, two major toxins. It causes diarrhea and then inflammation of the colon. There's two steps to infection as shown in the bottom right diagram here, and that is different from other HAIs. You know, we're starting to learn more and more that other infections may be more likely if patients have received antibiotics, but nothing's as associated with antibiotics to the degree that C. difficile is. So what are some of the issues we want to discuss tonight, or controversies? One question that I think is very important for the advocacy community is our CDI rates, we abbreviate this CDI, C. difficile infections. Are they beginning to decrease? We'll talk about why that is a little bit difficult to decipher. And then related to this is how should CDI be diagnosed? And there are different tests out there, some that are much more sensitive than others. And I think that, Kevin, you mentioned that probably a lot of people want to talk about whether we should be doing active surveillance testing or screening for C. difficile in the way that we do it sometimes for MRSA. And that relates to this third question, and that is how many asymptomatic carriers are there? And there are a lot. But just have we been able to show whether screening and isolating patients who are carriers will reduce C. diff rates? And we'll talk about that. And then how long should patients with C. difficile infection be isolated? And is there a transmission in outpatient healthcare settings? This is sort of a hot topic too. First of all, are rates decreasing? And first we need to know that for a long time, up until very recently, we didn't have any surveillance system for C. difficile infections. So we had to rely on data like this. This is administrative data. This is billing data, basically, for hospitalizations in the United States. And when we started to look at this for discharges that were coded for C. difficile infection, we found that there was this marked increase from 2000 to 2010. Well, it was late 2008 or so that we started to do surveillance, and we can talk about that in a moment. But this data, at least the hospital discharge data, suggests that we have plateaued or maybe even continuing to increase at historically high levels. And really it is probably plateauing discharge data, but there is some reason for some encouragement that there is some early decrease, and I'll show you why we think that. Let me talk a little bit about surveillance. And so we just had that discharge data I mentioned to you up until about 2008. Then we started in the National Healthcare Safety Network, abbreviated here NHSN. We started to collect data. Actually, here you can see 2010, 2011. Was when we really first started getting a number of hospitals. At that time, we only had this many hospitals reporting because some states had mandates. Now, all acute care hospitals are reporting into NHSN the C. difficile infection, what we call LabID events. And we actually don't just report the raw rate of C. difficile infections. We don't report the raw incidence, and I'll show you why in a moment. Most importantly is because there's some things that are affecting that, especially diagnostic tests, because we'll see in a moment that some tests are twice as sensitive as other tests. So we actually report what's called a standardized infection ratio, and that's abbreviated on this slide as the SIR. And maybe you know about this from, say, CLABSI and other MRSA reporting. The standardized infection ratio means that you're accounting for things that are beyond the hospital's control. So first of all, this is the measure here is really hospital-onset C. difficile. So it's anyone who gets diagnosed with C. difficile in the hospital greater than 48 hours. Actually, it's on the fourth hospital day, with date of admission being day 1, on or after the fourth hospital day. So that's the measure, the hospital-onset C. difficile. But we account for these things here in this model here. We look at the hospital bed size. We know that larger hospitals seem to have higher rates, and that might be because they have a more severely ill patient population. Also, teaching hospitals. But most important on this is, well, two things on the bottom here. The CDI test type, and you see that abbreviation there in the lower left, NAT, N-A-A-T, or PCR. These are molecular tests that amplify the DNA of the C. difficile. Nucleic acid amplification test, that's the abbreviation NAAT, or enzyme immunoassay, EIA, listed here. These NAT tests are about twice as sensitive, and so any hospital that's using one of them will have higher rates, and so we account for that. The other thing we account for is this prevalence on admission. This is the number of cases coming in to the hospital. The amount of C. difficile coming in the front door, this means the cases that are diagnosed in the first 72 hours or 48 hours, actually, in the period from admission to where hospital-onset cases are first being counted. Those cases are an indirect measure of how much C. difficile is out there in the community. Some of those cases, of course, could come back, be readmitted from the same hospital. Well, we exclude those, but just those cases that could be coming from other facilities or be coming from the community. We account for that because we know that when hospitals are in a neighborhood where there's more C. diff coming in their front door, they're going to have more pressure on them, and there's going to be more cases that occur in their hospital as well. So we control for that also in this model. And this just shows some parameters, and I won't go into detail here. These are just parameters or numbers that you adjust the rates on, and this is all goes into the SIR. So if we look at this progress report, which came out last January or February, we see that actually in the lower right-hand corner of it, that C. difficile infections, this is in 2013, had decreased 10% from the baseline, and the baseline was 2010 and 2011. Most of that decrease was in 2012, and then there was about another 2% or so decrease in 2013. So what we're saying here is that we look at hospital-onset C. difficile, and we account for, most importantly, the type of diagnostic test being used. There is an appearance of actually a decrease that hospitals are at least getting some handle on controlling C. difficile transmission. So it's just some early, 10% is nothing to write home about when we consider how high it is and everything, but just that we want to make it clear to people, yes, you can prevent C. difficile. I think it's important that we talk that there is some early movement in the right direction. And we know from another surveillance system, I don't have the data here, but that maybe there's also some signal that we're starting to control C. difficile in nursing homes also. It's not in this data. Let me just say something about the diagnostic test. I already mentioned how the nucleic acid amplification tests are very sensitive. Actually, there's another way you can actually culture for the C. difficile organism itself, and then you prove that the isolate produces the toxins. There are some strains of C. difficile out there that do not produce toxins, but you can see that they are on the top here on this list, this hierarchy of sensitivity, and they are more sensitive than some of the other tests listed here. I mentioned the toxin enzyme immunoassays. They're down here towards the bottom, toxin A and B, EIA, but then there's above that is this GDH test, the cell size toxin assay. So clearly the molecular tests are more sensitive, and in fact, you can see hospitals sometimes when they've switched to a nucleic acid amplification test, their rates will go up. Their rates may double, and that's why we do all that I mentioned in terms of controlling for that in our surveillance. But I want to mention also that there's some growing concern out there in the scientific community about nucleic acid or the PCR, the molecular tests, being too sensitive, okay? That maybe they're picking up more and more of these patients who are just colonized and maybe have diarrhea for some other reason. And I think that we were, a couple years ago when they were first developing these sensitive molecular tests, we were excited about them. We felt like we needed more sensitive tests. But the challenge is when you use a very sensitive test, you need to be sure that you're testing the right patient population. And that's sort of shown on this slide, that a diagnostic test in terms of telling you whether you have a certain condition depends a lot on the population that you use it in. And if you use a test in a population of patients that really are not likely to truly have disease, you can just find more false positives than true disease. And that's what this slide is just trying to show. And I won't spend a lot of time on it, but just to say that important in the diagnosis of C. difficile, as important as what tests you use, is who you order it in, and really determining whether people are likely to have C. difficile or whether they could have diarrhea for other reasons. And that's a problem sometimes because some labs are not really looking at that. They may not have much say in who gets tested for C. difficile. And this is actually a slide from Dale Girding, and we have been discussing this issue quite a bit among experts, and I think that this might be where the nation should be on this issue, and that is that the best thing would be that labs be working closely with their medical staff in terms of looking at the population of people being tested and be sure that the tests are being used in the right way. And we can talk some more about that during the Q&A. But as I'm alluding to, is that there are patients who are carrying C. difficile. They may even have some diarrhea for some other reason, but they're carrying C. difficile, and the C. difficile isn't really causing the infection. And this sort of shows this. This is a study from Vivian Liu in Canada where she was doing serial cultures for C. difficile. And you can see on this slide that as people are in the hospital longer, days since admission to a ward, that a certain number of them are developing up to 0.1% or so are developing C. difficile, actually up to 10% here because there's cumulative probability. So at 45 days, the red line suggests maybe 5% to 10%. The blue line, though, is really up there at 15 or 20% at the end of that time. So there's always more patients who are just colonized. And here in this study, these colonized patients were by definition asymptomatic. So just as people are developing C. difficile, also there is colonization going on. And a lot of this is people, as I mentioned before, people don't really become colonized with C. difficile normally. We don't carry it around with us. If we're healthy out in the community, at least adults do not normally carry C. difficile in their intestines, in their stool. But if you get on antibiotics and get around other patients with C. difficile, you may become colonized. And you may become infected, or you may just remain colonized. And so on the surface, it would look like that, yes, we could do active surveillance testing and then try to isolate these patients who are just colonized. And it is an area of active study, but we need to realize that there can be a lot of these people, a lot more than probably MRSA in most situations. You can see here different studies and the proportion of patients in these studies who were colonized. You can see that in a couple of these on admission to some settings, it may be 15% or more who are colonized. And as I said, there's no study to date that has shown that isolating these patients will reduce overall C. diff rates. Now, it makes sense that it could work. There are some studies doing just that, but it is different from MRSA in the sense that it is a spore, and it may not be as feasible to actively survey patients, isolate them, and reduce transmission. Again, it's something that is actively being studied. I'm aware of one uncontrolled study looking at this. It's also challenging, I should mention, that there isn't really any tests that have been developed just for this purpose. Now, there is a little bit of data that suggests you could use the molecular tests that I've mentioned, these nucleic acid amplification tests. They aren't quite as, well, they're not as sensitive as the culture. The problem with culture, like MRSA, where a culture method using some special augers, you could get a result in maybe 48 hours. With C. difficile, a culture takes several days. So I think another bottom line here is we don't really have surveillance tests also. But there is this increasing recognition that asymptomatic carriers are playing a role. So that's why it is worth studying, and I think that's why there's the interest that when we're using some of these, we have these new molecular methods, and these studies are suggesting that there is a role of these asymptomatic carriers, especially the study by Curry et al., where they were able to link the second set of bullets here, where they were able to link 29% of new cases to an asymptomatic carrier. And, this isn't totally surprising. It's as we get better at controlling transmission from the symptomatic cases, asymptomatics are going to play a bigger role. And it also suggests that using these more sensitive nucleic acid amplification tests, even though I mentioned all the problems, the concern about the problems with detecting asymptomatic carriers and treating them as if they had infection, if someone has diarrhea for some reason, having more sensitive tests may help with infection control. So sort of a double-edged sword there. Use a more sensitive test, you may overdiagnose C. difficile in people that just have maybe loose stools because they got a laxative recently or something like that. But on the other flip side of it, if you get them in isolation because of a positive result, that could help with transmission. So you can see where this is controversial and a bit of a quandary, but I think right now, in terms of where we have evidence for controlling transmission, it's really around using infection control on the diagnosed case of C. difficile and focusing on them. Some people are looking at going further than that. But another area too, well, this just says some more of that. Asymptomatic carriage, just to summarize what I said, asymptomatic carriage increases with healthcare exposure over time, especially antibiotic exposures, and especially in older people. And asymptomatic carriage does contribute to transmission, and people with diarrhea and C. difficile in their stool may well have C. diff infection. In fact, that's usually the criteria. But even if for some reason they had diarrhea only because they got a laxative or something like that, the diarrhea can spread the organism around as well. So right now in the U.S. at least, infection control and treatment decisions are linked on diagnosis of C. difficile. In England, what they've sort of said is to use a more sensitive screening test and then use a confirmatory test to determine whether someone is likely has the C. difficile in their stool and it's causing their disease, but use the screening test results for isolating patients. But the other thing that this sort of points to is if we could reduce the duration and degree of asymptomatic shedding, we could possibly reduce transmission. And this slide shows the fact that patients who are treated with vancomycin, I think most of the folks on this call probably know that the main treatment that we're using for C. difficile right now, fortunately or unfortunately, is another antibiotic. So, of course, we're treating a disease that usually was probably precipitated by antibiotics disrupting the healthy bacteria in the gut. We're now treating it with another bacteria, and that, of course, has something to do with why we see recurrences. So the main treatments are vancomycin, which is the only FDA-approved drug for C. Well, not the only one. The main drugs are vancomycin, metronidazole, and now fidaxomicin. So there's two drugs. Two of those three are FDA approved for C. difficile. That's vancomycin and fidaxomicin. But metronidazole has also been used for a long time in this area. As you can see here, while patients are on the vancomycin or metronidazole, their C. diff numbers go down, or they go down while they're on it. At the end of treatment, many of them may have negative cultures, but then after treatment, some of them come back with positive cultures again. And I don't have it on a slide, but if you look at the numbers of organisms too, they sort of mirror this. And then the number of organisms is important because the number of organisms in the stool predicts somewhat how likely someone is to contaminate the environment, as shown on here, that if there's more organism in the stool, that their skin is more likely colonized, and the environment is also. Let me just turn to one other area of controversy, and that is in the outpatient setting. Is there transmission in the community? As you know, that about 35% of all C. difficile is community-associated, meaning that the patient has not been in any overnight stay in a healthcare facility for at least 12 weeks. Most of these patients with community-associated C. difficile have been in a doctor's office, dentist's office, or other outpatient visit shown here. Most of them have. And you can divide up some of these outpatient exposures by what we called in this study as low-level exposures or high-level exposures based upon how close they are to maybe inpatient care or how intense they are. Only 18% of all the community-associated disease is in patients who've had no recent inpatient exposure. But there is some concern, and this is one study, the only one I'm aware of, that looked at contamination of ambulatory settings, outpatient settings. This is in the VA. They cultured environmental surfaces, including examination tables and things like that, and chairs and physician areas Also culture the patient's skin, abdomen, hand, arm. These are patients who were recently in the hospital with C. difficile infection. Their disease has resolved, and now they've come back for an outpatient visit. And you can see that these patients, even though they're now asymptomatic, they're shedding and they're contaminating these environmental surfaces, suggesting that there could be opportunity here for transmission in the outpatient setting if another patient came along who had recently been on antibiotics. So in this one study, the idea was that these patients should be dealt with using some enhanced precautions in the outpatient setting. And we're looking at this closely right now in a case control study in the community to see if outpatient visits are a risk factor independent of antibiotic use. You can see on here that, of course, all these patients with community-associated disease, well, at least 64% of them have had antibiotics. So that's one question that comes up is an outpatient visit a risk for C. difficile just because that's where they get the antibiotics, or is it because there may be transmission occurring also? But certainly right now the focus should be on antibiotic stewardship, and the most common reasons for these antibiotics are upper respiratory infections. A lot of those people probably don't really need an antibiotic, or dental procedures, and some of those patients probably don't need an antibiotic either. Anyway, so let me stop there, and I'm sure I probably totally confused you about both the diagnosis and this issue of asymptomatic carriers. And Kevin, you may have been expecting me to say that asymptomatic carriers are not important in transmission of C. difficile. No, they're probably increasingly important. And the reason that they're increasingly so is because we're probably doing a better job of preventing transmission from the symptomatic cases. But we don't have the evidence right now that we could, like we do for MRSA, where we have evidence that, especially in outbreak settings, if you actively survey for MRSA and isolate patients who are just colonized with MRSA, you can contribute to the overall transmission. We don't have that same level of evidence for C. difficile. Meanwhile, as I've said, there is this conundrum around diagnosis, where in Europe, or England especially, they are really trying to promote using a less sensitive test to determine who has C. difficile infection versus who does not. We are generally using more sensitive tests. Those may have a benefit, though, in infection control for all the reasons I mentioned, because they are determining if someone has C. difficile or not, even if it's not so good at always differentiating who is really infected. There's this different, this challenge with infection versus colonization. We like to just say someone who's colonized is asymptomatic, someone who's infected has diarrhea. But in fact, what happens sometimes in the hospital is people are colonized, and maybe they've even had C. diff before, but now they're really resolved, and they just get put on a laxative or something. Well, that kind of messes up the whole diagnosis. So I think you can understand how sometimes that confuses the picture. So anyway, I'll stop and entertain questions. Let me answer one of these questions from Kathy Day. Do you see value in using high-quality probiotics while on antibiotics? Many swear by them, and I wonder why they are not recommended by doctors. Okay, well, that's a great question, and I thought about maybe including that. But there are now several what we call meta-analysis. This is where investigators will comb through all the literature and look at all the studies on probiotics and put them all together and look at whether they are saying the same thing. And a couple of those now have been done, and they're saying that there is evidence that probiotics do work in preventing C. difficile. So, and one of these is even what's called a Cochrane review. So the question comes, you're posing, is why aren't doctors recommending them? Well, part of the problem is that you look at these studies and they're all over the map. And so we're sort of stuck with what probiotic, given in what dose, given when. And if you're going to make a recommendation for a national guideline, you really need to have that kind of information. And this points back to the problem is that all these probiotics that we're talking about right now are sold as nutritional supplements. They are not regulated by FDA as drugs. In the case of a drug, FDA regulates differently, and the approval process is more stringent and requires the company to really study them in a certain dose, a certain potency, and a certain dosing regimen. And so That's part of the problem, is that we don't have that critical mass of evidence. So what I generally tell people is that, as you know, the probiotics are, by the FDA, generally recognized as safe. That's GRAS, G-R-A-S, generally recognized as safe, and that's generally true in hospitalized patients. The big exception is in cancer patients or patients getting bone marrow transplants. There you need to be careful, because there have actually been cases of people getting the probiotic actually overgrowing in their gut and causing bloodstream infection. But in any other patient, they're generally recognized as safe, and certainly doctors are actually using them, or at least they are being prescribed by some doctors.